Okay. Well, it's 1 past 12, 2 past 12. Can everyone hear me? Yeah, thumbs up. Brilliant.
Yeah, it's good, Sam.
Brilliant. Okay, great. Okay, so we're going to make a start. There'll be people joining us as time goes on. So welcome to the 10th online National OGMDT. Many thanks for the team who organised this for allowing us to present 3 cases, which we're going to start with very soon. So we've got, so my name's Sam Metter, I'm one of the upper GI surgeons here, and we've got 3 very interesting cases for you to listen to and participate in. So we will have some Slido polls throughout these presentations that you can interact with, and where you can voice your own opinion. I'll quickly run through the order of the presentations just before we start. So the first is a recent gastric cancer case, which will be presented by myself, where we're going to examine staging, in particular the role of laparoscopy, peritoneal washings, evaluation of cytology, and the detection of occult metastatic disease in gastric cancer. We then have a case which is going to be presented by my colleague, Mr. Andy Cobain, on salvage options after definitive chemoradiotherapy for esophageal squamous cell carcinoma. And then finally, my senior colleague, Mr. Jez Hayden, will present an interesting case of a patient who underwent a salvage esophagectomy after DCRT, but had some post-operative problems relating to interstitial lung fibrosis, which is a condition that he was found to have. So throughout all of these presentations, we also have Dr. Hannah Lambie, who's our senior upper GI radiologist, who will be presenting and taking us through relevant imaging. Just a couple of things before we get started. The first is that we are recording this session, so that you're all aware, so that for people who can't join us live, this will be available for about a week afterwards. Secondly, you will have the opportunity to ask some questions at the end of each presentation. Best done so by raising your hand, and we'll try and get to you. Throughout the presentations, if you keep your video off and keep your mics turned off, by all means use the chat function. We may not be able to answer the chat function as we go along, particularly when we're presenting, but feel free to chat amongst yourselves. And the final thing is that in the last 10 minutes, we will have a presentation by, I think Dr. Lizzie Smythe from Cambridge to talk about an interesting study that they're doing. So without further ado, we're going to make a start on the first presentation. Okay, so this presentation is on peritoneal cytology in gastric cancer, and I'm going to present a patient by the initials GP, and he's a 67-year-old male. He presented with dysphagia, and he went on to have a gastroscopy, which identified a malignant stricture in the lower esophagus. This was impassable through the scope, and the biopsies confirmed adenocarcinoma. He then went on to have a CT and PET scan. And Hannah, I'm just going to show the slide. Could you just tell us a little bit about his cross-sectional imaging?
Yeah, absolutely. So he was referred in, as Sam said, as an esophageal cancer, and it was referred in as a TXN0M0 because there was nothing to see in the esophagus. But when we looked at the MDT, we were a bit worried about this thickening with the yellow arrows along the proximal, so extending from the cardia just along the lesser curve. So we thought in the MDT, this looked like it was a bit more advanced than initially thought. So a T3 disease, the green arrow points to a small node that we thought was involved as well. He went on to have a PET, as this was thought to be a junctional tumour, and we would always do a PET in these cases. The primary tumour was not avid, so there's no avidity in either the esophagus or that bit extending along the esophagus, so the PET's not added anything. So at this point, we're sticking to our stage of T3N1M0 junctional tumour.
Okay, thank you very much, Hannah. So we reviewed him in our upper GI MDT, advised that he should have a surgical clinic appointment. We saw him in surgical clinic. He was reasonably fit, a type 1 diabetic, PS1, managing a soft diet, which was good. And we sent him off for a CPEX test. And I won't bore you with all the details, but essentially he was fit enough for resectional surgery. His VO2 at anaerobic threshold was 12.9, and he had good pulmonary function tests. So I'll just, if I can go backwards. I don't think I can go backwards, can I? My thing is just broken down, I think. I've had a bit of a malfunction here. So I can't do my Slido. I'll try and get it sorted for you in a moment, but I think not entirely sure.
Sam, you probably won't be able to see this while you're trying to present your slides, but while you're doing that, Guy Blackshaw's got a hand up, probably wants to ask a question. If you want to come in at this point.
Yeah, thank you. Guy Blackshaw from Cardiff. Just whilst the technical issues have been sorted out, I was just going to say, has this patient did the patient have any US to assess the proximal extent? Because he kind of, it's probably a CVIT type 3, isn't it?
Right. Can you see this slide, by the way?
Guy, I'll jump in and answer that question while Sam's sorting out. I think it was an obstructing tumour. So when it was referred in, as an obstructing tumour. So we didn't consider a US because we thought we would get through it at that point. Having said that, I think they subsequently did get through it at OGD, but we were sold it as an obstruction.
Oh, I just wondered because Sam said that he was tolerating soft diet, so I didn't realise it was that bad sort of stricture.
Right. Okay. Can you see that?
Yes.
Good. Okay, brilliant. So following on from what you've just asked, we're going to run a poll. So very easy. You just put your phone camera onto the QR code and let's see if we can do an active poll with regard to what the next step for this patient should be. I don't know how many people are actually listening in live. Actually, I can't tell. So we'll leave this poll running for another 20 seconds or so. So I don't know what happened before. I think it just completely malfunctioned, but trying to integrate Slido with PowerPoint and Teams has been a bit of a nightmare.
We can't choose two options, can we? It's got to be just one.
It's got to be, unfortunately, it's got to be one choice. Sorry, I suppose a number of you would go for EUS as well as laparoscopy and OGD. Anyway, so far the polling suggests that we should go predominantly for staging laparoscopy and OGD, which is good, because that's exactly what we did. So we did a laparoscopy and OGD, and we found that the tumour was visible, as Hannah saw on the CT scan, extending into the lesser curvature with macroscopic evidence of serosal disease. Greater curvature spared, didn't go beyond the incisura, but there was enough stomach to form a gastric conduit if we had to do so. But what was also interesting, which wasn't visible on the CT scan, was there was a bit of fluid in the pelvis, and there was also a white plaque. So the plaque was obviously biopsied and peritoneal washings sent. Gastroscopy identified a non-traversable tumour at 40 centimetres and it appeared to be starting at the level of the Z line. So these are the results of the biopsy. So the peritoneal biopsy showed no evidence of any malignancy whatsoever. And the cytology, just to conclude, the cytology description, essentially cytology consistent with adenocarcinoma cells, consistent with an upper GI primary. So the next poll is what we should do from here. So the options really are, so this is a patient who's got a proximal gastric cancer, cytology positive, no obvious peritoneal disease. What should we do? Should we proceed with neoadjuvant chemotherapy, flock 4 cycles and then restage? Should we go for neoadjuvant chemotherapy and then plan for surgery after a repeat CT scan? Or should this patient be palliated and have palliative chemotherapy only?
Sorry, Sam, can I just ask a supplementary question? Was there so for me there's a big difference between just sampling the ascites that's there versus actual peritoneal washings and then suctioning those washings, especially in somebody who's got disease on the serosa, and I would see that those two as distinct different entities. Was this just ascites that was sampled that had malignant cells, or was it washings and then that sent off for cytology?
Good question, Andy, Mr. Cope. So I didn't do the staging laparoscopy. I think, Andy, did you do it?
Yeah, probably did, Sam. So if there was ascites there, I'd always send that separately before doing any washings. I'm not a big believer in the value of washings myself, but if there was ascites there, I'd have taken that and sent it separately.
Yeah, bro.
Okay, so the majority of people out there, half of the responders felt that this patient should simply be palliated. Maybe slightly less. There's another group of people who feel that neoadjuvant chemotherapy and then restage. And then a smaller group of people who feel that we should just go ahead with surgery. Okay, so we'll close the poll at this point, although people are still responding. Okay, so what we did is that we proceeded with neoadjuvant chemotherapy. We gave him 4 cycles of FLOT, and he completed the chemotherapy without incident. He then went on to have a follow-on CT scan. Hannah, would you be able to?
Yeah, absolutely. So we struggled earlier to see the primary. We struggled again, but we felt it hadn't progressed. We thought that node had possibly slightly reduced in size, so we thought there was a potential partial response, and we couldn't see any ascites. So potential partial response and no ascites.
So we then saw him in clinic, and I put it to him after discussion in the MDT that we should proceed to a repeat laparoscopy. And I explained to him that if the cytology results showed evidence of adenocarcinoma on peritoneal washings, then we would be proceeding down a palliative route. And he also acknowledged that if the washings were negative, then we would proceed to a resection. And he was actually very keen to proceed to surgery. And in terms of the resection itself, with regard to what operation he should have done, I explained to him that given the information that we had so far, that this was likely to be best resected through an extended total gastrectomy rather than esophagectomy. So he then went on to have a repeat staging laparoscopy and a very minimal amount of peritoneal fluid, really, nothing that you could easily sample. So he had a lavage and cytology sent. He also had some whitish lesions in the left lower peritoneum, which were strictly indeterminate. We biopsied these. Histology from these biopsies showed no evidence of any malignancy, and cytology essentially showed atypical cells. So they really couldn't tell what these cells were. They were suspicious, but not conclusive. So we're now going on to our third poll, which is where we should go from here. So the options here are whether we proceed to a resection, whether he should be going down a palliative pathway, or alternatively, he should have further chemotherapy and then reassess with further investigations, be it a CT cross-sectional imaging and perhaps even a further staging laparoscopy. There's obviously 80% of you, the majority, feel that we should be going down a palliative pathway now for this patient, although a smaller proportion feel that we should proceed with resection. And so far, no one feels that he should have further chemotherapy and then reassessment. Okay, that's all very interesting. So we'll tell you what we did. So he got sent off for another couple of cycles of FLOP. And then he had another CT scan. Hannah, can you?
It's just, yeah, showed very similar appearances to before. So again, we were still struggling to see the primary tumour. Again, no evidence of progression, no new sites of disease. Again, we still couldn't see any ascites on the CT. So we thought that node hadn't come back. So ongoing potential partial response.
Okay, so at this point, he's now 6 months from diagnosis. We had a discussion again, and we decided that we should proceed with resection. So we did consider the option of doing a further staging laparoscopy. The patient was very keen to proceed with the resection. And really, when I saw him, I didn't really have a clear reason why not to. His performance status was good, and he wanted to proceed. So he ended up having an extended total gastrectomy, and this histology shows a YPT4A, N0R0 cancer, TRG3, and 0 out of 19 lymph nodes involved. He made a full recovery, and then he was further discussed in the MDT to consider adjuvant chemotherapy. So he then went on to have 2 further cycles of FLOT. So he had a total of 8 cycles. So at this point, I'm just going to summarize what happened to him. So he had an index CT scan, staging laparoscopy. He was cytology positive, had 4 cycles of chemotherapy, tolerated that well, had a further CT scan which showed a probable response. He had a further staging lap which showed atypical cells, but inconclusive, then went on to have another 2 cycles which were tolerated well, and he had a CT scan which showed, again, a possible continuing partial response, and then he had surgery, and now he's had a further 2 cycles of FLOP. So just a couple of slides on the role of peritoneal cytology in staging of gastric cancer. So first of all, obviously, we all know that not all UK surgeons perform peritoneal washings during staging laparoscopy. What someone has already pointed out was that the situation was slightly different in the first laparoscopy in that there was fluid there. So it wasn't washings, there was fluid that was actually sampled. Positive cytology obviously is undoubtedly prognostically bad news, but there were positive indicators of potential clearance of the cytology positive disease by chemotherapy, notably the absence of ascites or the absence of fluid on the second laparoscopy. But of course, these indicators were not conclusive. And my question is really whether we have operated on this patient a bit too early, perhaps. And just a second slide, just to point out that really there isn't any real level 1 evidence on what to do. The slide on the right shows what they do in Memorial Sloan Kettering. You can see that they give a very extended plan for chemotherapy and have at least 3 laparoscopies before they even decide whether a patient should proceed to surgery. And so the question is really, well, we know that long-term survival is rare, but whether protracted chemotherapy with a longer interval to detect response may be the best option. So, final slide poll from me. So what should we do with cytology positive gastric cancer? Should they have palliative chemotherapy only? Should they proceed with a standard regimen of chemotherapy, i.e. FLOT and then gastrectomy? Or should they proceed with neoadjuvant chemotherapy and then give them a bit of benefit of doubt and do a repeat staging laparoscopy, and if cytology negative, proceed to surgery? That's the third option. And the fourth option is proceed with long course chemo for potentially a longer period of time, 1 to 2 years, and only consider gastrectomy if disease is stable and responded and cytology negative after this time. So feel free to respond to this poll. This will be really interesting to see what the audience feel is the best way forward for these patients. Right, so that's all very interesting. So obviously no one believes that these patients should just, you know, proceed with the normal route, which is neoadjuvant chemotherapy and then gastrectomy. Most would give benefit of doubt and repeat the staging laparoscopy and leave the option of surgery open. Slightly smaller proportion would go just down the palliative route completely, and only 7% would think that long course chemo, that would be palliative chemo, of course, for potentially 1 to 2 years would be the best way forward. Okay, we'll close this slide now. Okay, so just to finalize what happened to this patient. So he was reviewed in oncology clinic 3 months after surgery, after completing his, remember he was having 8 cycles of chemo, so he completed his final cycle of chemo and he was reasonably well. So the oncologist decided to check tumor markers and the CA19-9 was elevated. And so a CT scan was booked. And this CT scan is 3 months after his surgery. Anna?
Yeah, and sadly it shows widespread peritoneal disease. So you can see the ascites, the omental nodularity, and even solid peritoneal deposits in the pelvis as well, unfortunately.
Okay, thank you very much, Hannah. So the final slide is really any questions. I'm going to stop sharing my presentation now. So obviously I can see there's been a bit of chat going on in the background. Does anyone have their hands up? Anyone who's got their, so Samir Al-Badiri?
Yep. Hello.
Yeah, hi.
Hi. It is just a question and a comment, really. I mean, we treated with chemotherapy on the neoadjuvant side, and there was a question if it is stage 4 because the cytology was positive. Starting with the chemotherapy without knowing the HER2 status, we know that HER2 is positive. Adding trastuzumab to the chemotherapy showed better response. And nowadays there is room for immunotherapy from the start with the chemo. So I wonder if we label such cases as a neoadjuvant and not having the HER2 or immunotherapy may affect the survival or the recurrence of cancer. Thank you.
Thank you for that comment. I don't know if anyone's got any comments in response to that. No, has anyone else got any comments? I think I can't see who else has got their hand up, actually, unfortunately.
Hi, it's Chris
hi,
Peters
Chris.
from Imperial.
Hello.
Hi. Interesting case. I think our principle is we have Tim has said a number of times, we have an informed conversation with the patient and admit we don't know. But generally speaking, we believe there probably is a survival advantage when they go from cytology positive to negative with neoadjuvant. And we offer them resection, and you know we've got long survivors in that setting. I think the difference with this case is, I suppose, it was never proven that you cleared the cytology. There were suspicious cells the first time, and then you didn't repeat the staging lab. So I suppose we probably wouldn't have operated on this case. We would have made them. Well, no, we wouldn't have operated on this case. We'd have made them palliative after the second staging lab, or if we really wanted to push it hard, we'd have repeated the staging lab again. But I think there is a survival advantage to operate when they have become cytology negative. And then the other point is, where would PIPAC play a role in these cases? And the question is there going to be a greater conversion of cytology positive to negative, or even low volume peritoneal disease to peritoneal negative by using PIPAC in a neoadjuvant setting? And that's a very interesting question.
Thanks, Chris. Yes, I mean, what threw me was the atypical cells, you know, and putting this patient through a third staging laparoscopy, which he really wasn't particularly keen on having done. But that was my original plan, was to actually restage him. And after the third CT, I just thought, you know, he's had a response. He's had a number of cycles of chemo. You know, he wants surgery. Let's get on with it. And, you know, it was obviously, you know, in hindsight, you know, bad decision probably, in the sense that he has developed recurrent disease very quickly. So yeah, no, I take your point. Right, okay, so let's move on to the next presentation. So Andy, you're on next, aren't you? Are you able to share your slides? You're on mute at the moment. Yeah. Okay.
Yeah, let me find my slides for you.
Great, we can see that, Andy.
Okay, so this is a chap who presented with fairly innocuous symptoms. Youngish chap presenting with reflux, one episode of melena, and he went for an OGD on the basis of his melena, and was found to have a traversable tumour in the distal esophagus, biopsies confirming an SCC. He had a background history of used to smoke quite heavily. He used to drink quite heavily, but less so now, but still very active, working as a decorator and a good performance status. He went on to have some staging investigations, which Hannah will jump in at this point.
Yeah, so he had a small tumour. It was about 2 or 3 centimetres on the CT. It was eccentric, so it wasn't circumferential. It's that posterior located, small, almost lobular area. So on CT, it was T2/T3. We couldn't see any definite T3 extension, but we know we're not good at calling T2 and T3 on CT. So T2/T3, we couldn't see any nodes on the CT. So he went on and had his PET, which showed that the primary tumour was FDG avid. There was a tiny little node that just showed some very low grade background level uptake just above the hiatus. So T2/3, we were suspicious now about a node, so he went on to have an EUS to confirm local staging. And he was upstage on EUS. So you can see on that bottom right hand, there's some extension through the wall in keeping with T3 disease, and there was a positive appearing node. So T3, N1, M0.
Thanks, Hannah. So I didn't put a Slido poll on in terms of gauging who would only offer definitive chemorad or who would offer neoadjuvant chemorad versus surgery. Our approach in Leeds for these patients is to see them either in a joint clinic or separate surgical and clinical oncology clinics. And the patient met both the surgeons and the clinical oncologists. And on the basis of those discussions, the patient's choice was for definitive chemoradiotherapy, which he underwent at the beginning of February 2020. So he completed that successfully without any real dramas. He entered our standard surveillance program. He had a negative CT, endoscopy and biopsies at 3 months. And then around about 6-7 months started complaining of chest pain, adenophagia, persistent reflux, and had an out of surveillance barium swallow and CT scan, which were both normal. And then around about the year mark after completing his chemo rad, started complaining of new lower abdominal pain, still persistent reflux, but this pain and reflux were now waking him up at night. And he went on and had some more investigations. So Hannah will just talk you through a couple of those scans.
Yeah, so this was his initial, 3-month one. So on this one, we just saw a good response to treatment. So you can see there's now some circumferential thickening of the esophagus at the site of the previous, that polypoidal eccentric tumour, and we can't see any lesion at that same site. So we said this looked on CT like a good response to treatment and no new sites of disease. And then his subsequent one, so at 13 months, so I haven't shown you the esophageal pictures, but again, they looked like an ongoing good response. But now we noted a new left gastric node on the CT. Again, we couldn't see anything else further. So he went on to have a PET CT, which confirmed this left gastric node was FDG avid and no other sites of FDG avid disease. So it looks on imaging like he's got a solitary site of recurrence in a left gastric node.
Thanks, Hannah. So we discussed this in our MDT, and in particular, we looked back at his radiation fields, and the clinical oncologist told us that that left gastric nodal recurrence was right at the edge of his low dose radiation field. So can you see a Slido poll yet? No. Okay, I can't tell you why that's not going. There we go. So at this point, with an isolated left gastric lymph node recurrence, I guess the question for the MDT is, what treatment would you offer this patient? Would you look to give him further radiotherapy? Would you look to give him systemic therapy options? Or would you proceed to surgery, either a limited lymphadenectomy in the abdomen or a full salvage esophagectomy? So looking like a preference towards a salvage esophagectomy. I don't know how many, what the balance of surgeons compared to oncologists on the in the meeting
I really
is, and how
do
that might
hope, Andy,
influence
that it's not just us voting.
No,
There's
I
people
know.
outside of Leeds voting on this.
I know. But I think that that reflects what we felt. So our recommendation for the MDT was that he ought to be considered for a salvage esophagectomy. He was seen back in the surgical clinic at that point, but he outright declined an esophagectomy. He didn't want to undergo a big operation. We then rediscussed back in the MDT the role of radiotherapy, chemotherapy, and limited lymphadenectomy. And the patient's choice, after discussing those options, was for a lymphadenectomy. It was felt that the radiotherapy field would significantly overlap with what he'd had before, there'd be a high risk of toxicity, and so the clinical oncologists weren't keen to offer more radiotherapy. So he underwent a laparoscopic lymphadenectomy in the left gastric territory. He had all his lymph nodes cleared from the hiatus down to the incisura. Left gastric vessels divided, lymphadenectomy performed. There weren't any visible nodes around the rest of his celiac trunk, so those were left behind. And that lymphadenectomy package was sent to histology, and there was one positive node out of 13, consistent with the PET findings. So I guess my next question for the MDT is, having done a lymphadenectomy, would anybody add in any systemic therapy at this point? Okay, looking like a proportion, a majority of people thinking that some systemic chemo would be the right thing to do. I think that's really interesting because we don't usually give systemic chemotherapy after a salvage procedure, but this guy's got nodal recurrence. I don't know whether that changes, people's perceptions compared to recurrence or residual disease in the esophagus, but I think there's a strong feeling that he ought to be considered for chemotherapy. The discussion in our MDT and from our oncologist was that there wasn't any added value to systemic chemotherapy, given that he'd had a surgical lymphadenectomy, and he continued with standard surveillance. So he had a CT scan 6 months after his operation, which Hannah will jump in at this point. Well, can't see or hear you, Hannah. I don't know whether you've dropped off the call. But essentially, his CT scan
she's
surveillance
just
at 6
crashed
months.
out.
He's crashed out.
She's going to try and get back in a moment.
So this is asymptomatic patient at this point, had a surveillance CT, and there was concern for a new lymph node in the right hilum on CT, which she's drawn an arrow on over here. Patient went on to have a PET scan. That node was negative, but the PET did raise suspicion for recurrent disease within the esophagus. At OGD, there was nothing in the lumen to see, and the patient went on to have an EUS as well, and that showed sort of a plaque of abnormal looking soft tissue at the site of PET avidity, and biopsies of that confirmed sort of extraluminal SCC. So at this point, we counseled the patient that he really ought to be considering a salvage esophagectomy at this point. He was CPEXed and had an acceptable CPEX result, which is on your screen there. And he underwent a salvage minimally invasive esophagectomy, and histology, as you see, T3, N1, positive CRM, and he did very well and was discharged on post-operative day 9. So there's not a huge number of things I want to really discuss. I think there's maybe a few questions for the group. I think this is clearly a patient who had recurrent nodal disease outside of the radiation field. And the patient's perhaps gone down a non-standard treatment pathway, very much influenced by patient choice not to go forwards with an esophagectomy when we all thought that was probably the right thing to do. I don't know if anybody has any thoughts in the chat or wants to chip in how much or more strongly they might have tried to persuade the patient to have an esophagectomy first time around, whether they'd have been happy to not undergo an esophagectomy and to consider chemo or surgical lymphadenectomy instead, or whether they think that was the wrong thing to do. And I guess the second thing for discussion is what is the role for systemic therapies in patients that have nodal disease after definitive chemoradiotherapy? When would you add it? Would you add it in as part of the treatment package? Would you add it in when they relapse? One for the oncologist there. So Danny, I think you've got your hand up. Do you want to come in at this point?
Hi, Andy. Yeah, it's a very interesting case that you presented. I think what was interesting from the poll that you highlighted is that there are differences in opinion and whether patients should have adjuvant chemotherapy after the lymphadenectomy. As you say, you know, we don't normally routinely do this post-salvage, but this is an unusual case. And it's difficult. I'm not sure if there's a right or wrong answer here. You could argue for systemic treatments because of, you know, the nodal spread, but there is no, I think, definitive evidence to support either that I'm aware of.
I was just going to say, Andy, that, you know, we talk about salvage lymphadenectomy, and I think there are probably some case reports of doing that after DCRT, but it kind of doesn't make much sense really, does it? Because, you know, just because you can't find recurrent cancer within the esophagus doesn't mean it's there, you know, within the wall. And therefore it makes perfect sense to just proceed with salvage surgery, doesn't it? Would you agree with that?
I'd agree with that. And I think that's why a number of us were a bit uncomfortable in the NDT that the patient had declined an esophagectomy, and we felt as though he was having a second best treatment option, perhaps. But it was the patient was counselled on a number of occasions in the surgical clinic, and that's what he chose. So.
Yeah. So we've got Guy with his hand up.
Yeah, thank you. Yeah, I was just going to say, I mean, and obviously, you know, the preferred option would have been to do a salvage, but if the patient's got capacity and they've been appropriately counselled and they've refused an esophagectomy, then it is you're in the realms of a very bespoke treatment then, and you know, obviously, you know, you are limited with what you can do, and obviously, you know, you did what was thought to be best for this chap. So I think it's absolutely reasonable what you did, even though it's a bit left field, you know. And at the end of the day, we've got to respect patients' choices as long as they understand the implications of their choices.
Yeah, thanks, Guy. Sam, you mentioned evidence for salvage lymphadenectomies. There's really very little, you know, single figure case series, sporadic case reports, mainly for cervical lymphadenectomies after DCRT. Less so for abdominal recurrence, and there's certainly not enough in the literature to guide your decision making.
Yeah, no, absolutely. Well, do you think he should have simply been offered either a salvage esophagectomy or, you know, systemic treatment or whatever, and not even offered the option of lymphadenectomy? Do you think?
Well, I think that's the more interesting question, isn't it? I think if the patient's declining the first choice surgical option, you have to reconsider what his non-surgical options are and whether they are better than just a surgical lymphadenectomy. And I take the point that our oncologists didn't think that further radiotherapy was, well, they thought further radiotherapy was going to be too toxic. It's how strongly you push people to work outside their comfort zone from that point of view. There's no right or wrong answer. But I think we probably could have considered systemic therapy for him, or we did on a number of occasions. But whether we were right in not offering it at all in the pathway, I'm less clear. So
yeah.
Chris, you got your hand up.
Yeah, I think it's a difficult case, isn't it? Particularly when the patient's sort of declining things that are being offered them. But I think the point people made in the previous case about micrometastasis is important here. And I suppose the chances of the lymphadenectomy of just what you can see getting all the malignancy out seem to be low to me. And I think that's where systemic chemo might have been more beneficial in controlling disease. But it's difficult. And if the patient declined an esophagectomy, like Tim said before he left, you know, it's patient's choice.
So Chris, if that patient had disease recurrence in the esophagus and the left gastric node, and you'd done a salvage esophagectomy, would you then offer adjuvant chemo after that, or would you say that you've cleared?
No, not routinely, because we would have done we would have attempted to have done a radical enough operation that we would have removed all of the lymphatic drainage pattern and the primary. So we wouldn't have offered them systemic chemo then. But in this case, you'd only removed one area of lymphatic drainage, not the esophagus and not the other areas of lymphatic drainage. So that's why I think more chemo may have been beneficial. But no one would ever know. The patient was probably doomed from the start, bad biology.
Yeah, probably. And that's where, to my mind, I think giving the chemo after that limited lymphadenectomy had value, not necessarily after the subsequent salvage esophagectomy, but difficult to know.
Okay.
Lizzie, did you want to come in?
Yeah.
Oh, thank you. Really nice case, thank you. I just wanted to say that, I would, although you might consider them a little, platinum resistant because they've recurred after platinum, if we had the opportunity to add in some immunotherapy or change platinums, you could do that while they have considered metastatic disease, which is the lymph nodes present, but not afterwards. And so for that reason, and we are starting to see, better responses and longer term survival with immunotherapy plus chemotherapy. So that'd be one reason to consider that before surgery. And also might give them a little bit of time to think about it.
So Lizzie, are you suggesting immunotherapy before a potential operation?
Chemoimmunotherapy. Yeah, we can only give chemoimmunotherapy when they've got metastatic disease. And at the moment, only if they're PD-L1 positive. So I don't know what the state for that patient was, so it might not be relevant, but we should check because about 50% of squamous cancer patients are positive, and it really does massively improve response rates and could deal with the bits that perhaps you can't remove surgically. So my argument would be consider it metastatic, treat with the best metastatic treatment that you have, and then go for a resection.
Okay.
I think that's really interesting. I'm glad the immunotherapy has been brought in, because there is a slight nuance to when you're able to give it, which we're perhaps not used to considering that in the MDTs, but will be more and more so as we use immunotherapy more. So.
Okay. That's brilliant, Andy. Thank you very much for presenting that case.
Thanks, Em.
Our third case is going to be presented by Mr. Jeremy Hayden. So I'm going to hand over to him now.
Sorry, Sam, just trying to get my share going.
Sure, no problem.
Just trying to go back. There you go, you've seen it all. Right, so I'd just like to invite people to use the chat with this, because for feedback, because I don't have Slido facilities for my version of Windows that I've got. But essentially, this is quite a complex patient, 5-year-old male who in June 2020 developed poorly differentiated adenocarcinoma in a lower esophageal stricture. He had dysphagia for a few months and was tolerating a sloppy diet. He had no weight loss. He had type 2 diabetes. He had a right total knee replacement. He was a non-smoker. We usually do CPEX routinely for our major resections, and he had a good anaerobic threshold and VO2 max. And then went on and had a PET CT, which I think Hannah's going to show us. I can't forward now. There you go.
Yeah, so this was a fairly bulky distal esophageal tumour, about 6 centimetres in length. You can see circumferential thickening there on the axials and the coronal images. We couldn't definitely see any nodes. We know we're not great at calling nodes, but we couldn't see any definite nodes on this. On CT, it was a T3N0M0. And we proceeded to a PET CT, which showed the primary tumour to be FDG avid and no change to staging.
Thank you. So this is probably uncontroversial, really, I think, for hopefully all of you. But so T3N0 lower esophageal adenocarcinoma. Any thoughts on what sort of pathway you would go for this? I'm interested to see what people think. Can't see my chat at all. Don't know how to get it up. I know there are some people who would give neoadjuvant chemoradiation for lower esophageal cancer, but this is an adenocarcinoma. So I'll just give a chance for a few comments to come through. So someone's mentioned the CROSS study. and staging laparoscopy has been mentioned. So for this patient, we went down the lines of neoadjuvant chemotherapy followed by surgery, which would be our standard pathway in Leeds. I note that one of the comments mentions FLOT. In the context of the time of this, I think it was July to September 2020. We were in the midst of the COVID-19 pandemic, and there was a vaccination program starting at that stage. And if you can all remember, as far back as this, hospitals were all under varying degrees of surge for COVID, and critical care capacity was sometimes quite compromised. And we were all in various parts of the country struggling with what was going on around us at the time. Nevertheless, we decided at the MDT he should go down the neoadjuvant chemotherapy and surgery line, and he was given oxaliplatin and capecitabine as his chemotherapy regime. And he then, after chemotherapy, which he tolerated reasonably well, had a post-chemotherapy CT.
And so the primary tumour looked stable and there were no new sites of disease. There was a little bit of nodularity right up at the apex of the lungs there. It wasn't typical for metastatic disease, which is usually more widespread and more basal. So I have to say we thought that was just inflammatory and we sort of mentioned it and dismissed it. So stable appearances, and we weren't concerned for any new sites of disease.
Okay. So at this point, I'm guessing that there would be no reason to not proceed to go ahead. However, around that time in Leeds, we were seriously struggling with the surge of COVID. We were looking at significant nosocomial COVID infection rates, and I think it was talked about at one stage that approximately 1 in 3 to 1 in 4 patients that came into hospital were getting COVID. And so as an MDT, we had several meetings during the COVID pandemic, and we decided on various, we evaluated the pathway of all of our patients, and we decided as a team at that time to divert this patient to definitive chemoradiation as an alternative curative pathway to having surgical resection at that stage. As at the time, it was dreadful, and all of our theatre staff, most of our theatre staff were being recruited to go in and support critical care. So very difficult times, as I'm sure we all appreciate. And he had 50 grays in 25 fractions with concurrent carboplatin and paclitaxel, I may have pronounced that wrong, towards December 2020. Following his treatment, he then had a surveillance endoscopy in February that year that showed some ulceration in the lower esophagus, which was reported as suspicious for residual disease, but biopsies at that time were negative. He then, in March, had a post-chemoradiation CT scan.
So again, the primary tumour looks fairly stable. We know we can't differentiate on CT between treatment response and residual tumour, but it looked fairly stable and there were no new sites of disease within the abdomen. What there were, however, were progressive pulmonary changes. So that nodularity on the previous slide had got a little bit worse up at the right upper lobe. There was the next, the upper right slide shows some ground glass changes in the left lung, which was a little bit unusual. And then at the bottom, there was some septal thickening around the bases. Again, this was all just a little bit unusual, wasn't particularly fitting any patch. We thought maybe the ground glass, that again looks more like inflammatory stuff. So at this point, we weren't really sure what was going in the lungs. They did seem to be progressing a bit. Again, nothing was typical of any metastatic disease. So at this point, we suggested doing an interval scan. I think in about 3 months, we said after this one.
So in June 2021, he went on and had further endoscopic surveillance, and this time his lower esophageal ulceration was better macroscopically than previously. He didn't have any biopsies taken at that point because the procedure wasn't very well tolerated, and he then went on and had a further CT scan in June 2021.
So again, the changes in the esophagus were stable, so there's nothing new there, but his lungs had got a lot worse by this point, so further progression. There's quite a lot of nodularity, so that stuff at the apices has now spread to the other side, multiple tiny little nodules. There's now these reticular, so linear markings as well that we often see in all sorts of things. We see in fibrosis, but we also see in pulmonary edema as well. And then more specifically, there's this beading sign and septal nodules. So now there's nodules that are going along the pleura, going along the septi, and going along sort of the lingular things as well. And then this is a sort of unusual pattern that you don't see so often. So sarcoid is the thing that usually springs to mind, obviously not in this setting. The same sort of pattern you see in a sort of pneumoconiosis. It's not typically what's seen with a drug reaction or a drug-related fibrosis, but drug things can look very, very unusual. And then more worryingly, we also do see it in lymphangitis. So I guess in terms of the MDT, when we were looking at this, we were worried about, is this a lymphangitis that we're seeing, or is this a benign condition? But whatever it is, it's got worse. So we suggested a respiratory opinion at this point.
Thanks very much, Hannah. So meanwhile, for a respiratory opinion at that point, in July that year, he had further surveillance endoscopy, which again, esophagus biopsies at that stage confirmed once again adenocarcinoma, unfortunately for him. He had a repeat PET at that point. He had repeat assessment of his fitness because we were concerned about the lung changes reported on imaging. And we asked the opinion of our respiratory colleagues, who said that he should have a VATS lung biopsy of that one of those areas, as he could have another malignancy, or he could have an involving respiratory disease. So he had a repeat PET at that point, as we were considering his options.
So we couldn't see any uptake at the site of the primary tumour, and we didn't see any other disease elsewhere. So not upstaged on PET.
Okay, so from his VATS biopsy, which was done in September 21, we had a benign interstitial fibroinflammatory process. Our MDT and the discussion of our MDT on that biopsy seemed to be more focused on whether or not there was malignancy there. We didn't have, from recall, a detailed discussion about the lung disease. He did have a CT, however, in November that year, as his time was ticking along, and we wanted to just keep track of his staging. And that was November 2021. Sorry,
yeah,
is that
that was me being mute. So the primary tumour was, stable again. And actually, reassuringly on this one, there certainly wasn't any deterioration in the pulmonary changes. If anything, they were slightly better.
Thanks, Hannah. So if I was doing a Slido poll at this stage, I would ask people for what do you think next would be appropriate. He's a 76-year-old male now, type 2 diabetes. He's had neoadjuvant chemotherapy previously. He's also had definitive chemoradiotherapy as a diversion pathway through COVID. He has recurrent/residual disease. He also has some form of fibroinflammatory lung disease, but on CPEX testing, his most recent CPEX test shows that his cardiopulmonary performance was reasonable. So could I invite any chat comments? I'm going to look at my colleague's screen because I can't see my chat at the minute. But what would people do at this point, given the scenario? It's quite an elderly man. We also need to remember that COVID's still going on in the background, and he's already had quite a lot of treatment, and the issue is regarding the lung disease. What do people think? Listing it. So I think, I mean, essentially the options are probably going to be palliative or whether we proceed with curative treatment. Palliative options might include brachytherapy. It could involve putting a stent in whenever he's developed critical dysphagia. Could be an argument giving him further chemotherapy. He could have resectional surgery, which would be a salvage resection in someone who's in his situation. So someone asked, Chris asked, how functionally is he? So this gentleman is actually a 76-year-old now, but he's at performance status point of view, probably performing station treatment very well. He did report having a cough, which he said he'd had for about 12 months, but it hadn't been a major issue and hadn't caused him any significant restriction. But he did actually, when we went back and started asking him questions on receiving various CT reports suggesting he had evolving lung disease, we did quiz him about this, and he just said that he had a bit of a dry cough. But you know, with COVID going on, you know, any dry cough was assumed to have COVID as the cause. He actually didn't have COVID at that point, or had it at any time up to that point, and he had been fully vaccinated. So it's a tricky one. Palliative, curative, two big options, significant for this patient. Okay, I'll put you out of your misery. So in November 2022, he had a salvage Ivor Lewis esophagectomy, an open resection. His histology was YPT3N0 with no auto-21 nodes involved, R1 with CRM positive. It was CRM positive. His tumor regression grade was 4, indicating some response to his previous treatment, but not a significant response. On 22nd of November, he had a swallow that showed no leak, which we were pleased about. We're probably a bit old-fashioned in Leeds, still doing swallows, but we all tend to do swallows because radiologists need to keep busy. Sorry, Hannah. However, he did develop some concerning clinical signs, and on the 1st of December, he had a CT scan that showed a loculated effusion, but no leak of oral contrast. However, on the 2nd of December, it became obvious that he developed a chyle leak, and this is just for all my surgical colleagues in the audience. What do you do with a chyle leak? We managed it conservatively, as I'm sure you all would do. But what would you do with a chyle leak in your unit? Please feel free to offer any chat comments. It's not as good as a doodle poll, I know, but it's the best thing I can offer.
I think this was presented, wasn't it, in the last national meeting from Dublin, where they had an entire section on how to deal with a chyle leak. And I think at the time they did a Slido poll, and I think people favoured the interventional radiology option.
Okay. So he had a period of conservative management, and he then proceeded to interventional radiology for percutaneous gluing of the cisterna chyli and branches of the thoracic duct. At that point, the options would be either a thoracoscopy and minimally invasive approach to that, or a thoracotomy. This patient was in quite a fragile situation at that point, and I'm very grateful to radiology colleagues for taking that on, and it was successful. However, he did have major respiratory issues afterwards, with finding it difficult to mobilize without being too short of breath. He eventually did have a protracted stay in hospital, mainly due to mobilization and his breathing problems, and he was eventually discharged on February earlier this year. However, at the end of that month, about 2 weeks after discharge, he was readmitted. He tested positive for COVID, having avoided it for 2 years. He tested positive, and then it was discharged eventually towards the end of that month. And then in April this year, he was also readmitted again under the medical team with some urosepsis and Clostridium infectious stool. And I saw him a few weeks ago, and he's an inpatient still, but on a medical ward. He doesn't appear to have any recurrent disease, and he doesn't appear to have a surgical issue that I can help him with, but he's really struggled, and he's someone who we elected to go through with a surgical pathway on. There was an evolving pulmonary disease, and certainly I don't have a lot of experience of operating on people with interstitial lung disease. I did ask respiratory colleagues if anyone was free today to come and give us a little bit of information about this, but unfortunately no one was available at a week's notice, so I can't give you the benefit of any specialty involvement with that. But it was a difficult case, very complicated case. We put the patient through a lot, and but it's just, we are seeing a lot of pulmonary changes now on CT, and sometimes it throws up questions for us in terms of whether we should be operating or not. In this case, I think it was probably inevitable that we were going to operate, but his respiratory condition is clearly evolving. So I think that's as much as I want to say. I'm sorry I've spoken a lot, but it was a very complex case. And if anyone has any chat or questions, please feel free to chip in.
Okay, thank you very much, Jez. I don't see any hands up. He's still an inpatient, isn't he, at the moment? And it's going to be a struggle to get him home, I suppose. Yeah. So that's Chris has just mentioned that you got him through the surgery, Jez.
Yeah, I mean, we have to be grateful about this. Interventional radiology helps with that considerably. I think if we'd operated second time, I don't think that would have been the case. So, I think it's difficult. We've had another patient subsequent to that we've had to manage as the team, as part of the team with this type of condition, and the patient, unfortunately, their disease altered their management, and we didn't end up going down a surgical pathway with someone in a very similar situation.
I think Lizzie and Chris are trying to be nice about it. Lizzie's saying you weren't to know, and Chris is saying, well, it's not your problem anymore, Jez, anyway. Under someone else.
Yeah.
Brilliant. Okay, thanks, Jez.
Yeah.
That's fantastic. So we're done from Leeds. Thank you very much to my co-hosts, Hannah, Andy, and Jez. And Lizzie and Chris, are you there?
Thank you very much. I think Lizzie's got the slides in the Slido, so we're very grateful if you could stay on just for a couple more minutes.
I am. We want maybe 5 minutes of everybody's time, because this is an important discussion that we'd like to kind of put to the community, I think, about a study that has been in the works for a number of years. Chris, do you want to give a little bit of a spiel about it while I pull up the slides? Are you there? Oh,
sure. This is the oligo trial, which has gone through the NCR-AOG subgroup, which I have the honour of chairing, and has been around now for about a year and a half in various guises, and we're through to a second round of grant applications and are trying to finesse our thoughts. And the idea is that a lot of us believe that that metastatic disease in the current climate of immunotherapy, FLOT, and more treatment options in terms of more radical surgery, targeted radiotherapy, is not what it used to be. And there may be that what was once considered M1 palliative, perhaps now there are more options available. So the oligo trial is aiming to look at whether we can improve outcomes for these patients by considering low volume metastatic disease, potentially treatable depending on the site of that metastatic disease and the amount of that metastatic disease. So what we're very interested in is the opinion of this group as to what types of cancers should be put into this trial and what types of oligometastatic disease may be potentially treated. So Lizzie, do you want to slide up?
Thank you. Thanks for putting that so nicely, Chris. So as Chris said, the aim is to take those patients who we wonder if surgery could benefit them, but also whether anything in addition to surgery. So what we would be doing is surgery plus maybe SABR to any lymph nodes that they might have, or SABR or RFA to maybe isolated liver metastasis to clear the patients of disease, and it would be a randomized study. So, let's see. So we have a number of different questions. And if you can see, there's a different Slido there. So the Slido is at a different number. So anyone who has joined on the Slido before, I'd be really grateful if you're able to join it again at this number, which is 7870308. Can you all see that?
Yep, it's up, Lizzie.
Super. Okay. So I'll give you. Let's think about giving you. And so the reason why we have this question is because, oh, great. Okay, so and this I think will save as well. So some people, we do consider that maybe gastric cancers have a bit of a better prognosis overall, and wanted to put it to you whether we should include only gastric or only junctional. However, as you know, in the UK, we see much more junctional cancers than gastric cancers, and I think this is correct because I think we would limit ourselves to too few patients if we limit it to gastric cancer. Chris, do you have any thoughts on that? Not to bias the survey in any way, but
yeah, I agree. I think the subgroup analysis is clear here, but my feeling is that we might struggle to recruit based on only gastric cancers, and yes, that particularly depending on the answers to the rest of the questions, that GOJ cancers with potentially M1 lymph nodes in a limited area, etc., may be possible.
Okay. Now we're going to get into the nitty-gritty of what areas of the body or we should permit patients with metastasis to enroll in the trial. So should small volume liver mets be allowed, yes or no? I'll give you a little while to think about that, and I can prep the next question too, because we will go on to discuss how many liver metastases are important or should be permitted, and some of the studies in particular in Europe have been very permissive, but we're not sure that we should be as permissive as they should be. So the question is, it does seem that most of you did think we should allow small volume. Should we allow one only, 1 to 2, or 1 to 3? And as I said, some of the studies in Europe allow up to 5. I personally think up to 5 is too many. Oh, we need more than 2. Okay, so this is very interesting. So 1 to 2. We're at 1. Some are allowing up to 3. We need a tiebreaker. Okay, so it seems that most people are interested in perhaps permitting up to 3 metastases, and a minority for only 1 metastasis. What we haven't said here, Chris, I guess, is in terms of the time, is the size of the metastasis is important. And the site of the, perhaps, bilobal liver metastases, it could be important too. And that's something maybe we could have feedback on in a second, just after the survey, but I'll capture that. So we're feeling more permissive than 1, but 3 being the maximum. Okay, should lung metastasis be permitted in the trial? Let's get a yes or a no for that. Okay, yes, good. I think lung mets are a little bit more rare actually to see them synchronously, but we would agree with that. It's probably as easy to allow lung metastasis in as not. One person thinks no. Interesting. Okay, so we'll talk about that afterwards as well, or maybe it's more than one. Should we permit M1 lymph nodes, so lymph nodes outside the operative field? For me, this is probably the easiest yes. What do you think, Chris? So depending.
I agree, and you know, we in Oxford in particular already have a case series of sort of extended lymphadenectomy with really good outcomes.
We know also biologically that cancer that metastasizes only to lymph nodes has a little bit of a different biology than that which is metastasized to the liver, for example. So a majority supporting M1 lymph nodes. And should bone metastases be permitted? Yes or no? No. So I'm not surprised at that. Oh, yeah, there's a little bit more debate. So I think a majority for no. And I think I would personally, I would support that, because I think that when we see patients with bone mets, unfortunately, they do tend to have very poor prognosis. Even if they're isolated, I do think it heralds a much more diffuse metastatic disease. So I think that's generally in line with what we thought, and we all do seem to be on the same page. Now, this is an important question. If a patient has more than one site of metastasis, should we permit them in the trial? Yeah, so no. So this would be M1 lymph nodes and liver, M1 lymph nodes and lung, or no. So the answer is no to that, and I would agree, because that's suggesting it's more diffusely metastatic. Now, I'm not sure how many oncologists we have in the audience here, but for everyone else who would like to chip in, before we do a definitive treatment, so surgery plus or minus radical chemoradiotherapy to metastasis, should we give the patients 3 months of chemo and then move on, or more than 3 months of chemo? So really interested in your thoughts. So you are mostly up for 3 months of chemo. Okay, so and a minority for more than 3 months. I think that's interesting. My personal perspective is I'd like to have them have a bit more than 3 months, because my concern is that if you give chemo and the best chemo, so for example, if it was chemo and trastuzumab or chemo and immunotherapy, and then you do the curative surgery, then you can't really, they don't have metastatic disease at that point in time, so you can't really give that again after the surgery. So I would kind of consider it like to maximize the benefit of that. But if 3 months is the consensus, we'd certainly consider that. Okay. And I think that's the end. I think that's the end of that survey. So it would be, thank you all very much. I see Dan. Dan, are you doing a thumbs up for more than 3 months of chemo? I've just, because I couldn't see the chat. Okay.
I think he's doing it
that was
because
just an earlier question.
he predicted the question.
Oh, right, okay. I couldn't see that. I'd really like to take any comments that are here from the group, because, you know, in particular, I think that the surgeons are critical to this, because you will be the ones performing surgery on patients who've had metastatic disease diagnosed, and these patients will be coming through your MDT. So, you know, what works, what's important for you is really important for this trial and for patients. So any feedback on that? We've kind of settled on 3 liver mets. Are we concerned about size, bilobar, or is there anything that we haven't discussed that is important? So speak up. This is not definitive.
Andy's got his hand up, and Andy and Lee, is it? So Andy
Hi, thanks, Chris. Just to check I got it right at the start, you're considering metachronous rather than synchronous disease, aren't you?
No, this is synchronous.
Synchronous disease.
Yes.
Fine.
Because Sabre is funded for metachronous already. With this, we're going for synchronous, and that's why I would have suggested a little bit longer chemo. Sorry if that didn't make that clear.
No, I just wanted to be sure, because I was going to ask what your definition for metachronous was, but for synchronous, I'd definitely want to give a bit longer chemo, I'd have thought.
Yeah, I think so. I would be going for 4 to 6 months, I think, minimum. But I guess, you know, if you wanted to use the paradigm of colorectal cancer, with liver mets, I mean, I treat colorectal cancer too. We often do 3 months before surgery on the liver, but that's a different disease, and I suppose the prognosis is so much better. Who else? Danny had his hands up, did he? Oh, there's Tom back. Hello.
Ulla Hannah has got their hand up, but I'm sorry, I can't see your first name. I apologise.
Hi, it's Danny in Leeds.
Oh, hi, Danny.
about the duration of chemotherapy. You kind of alluded to it. Would there be any role for adjuvant treatment in your trial design, or?
Well, I think that you definitely could give adjuvant treatment at your discretion, but it would be hard to argue for the funding, for example, for
Sure.
pembrolizumab or trastuzumab if the patient had no disease after surgery, because we've in theory removed it, I suppose. And I'm not suggesting. I think we need to probably settle on a duration of treatment. Tom, did you want to comment?
Yeah, sorry, I had to go to the actual sort of clinical MDT, so I missed the first couple of slides and interesting questions, and I would sort of say at least 3 months of chemo. But this is randomised, yes?
Yes.
So it's for patients where we think there's equipoise, and I think it is really complex because these are a whole range of different patients, different diseases, different biologies now, aren't they? And so it'll be for patients who ultimately the MDT or the oncologist or the surgeon, has equipoise in their mind about whether it's right. And we've got to remember, if we don't know, a randomised trial is a good thing to do. But are you stratifying by, HER2 status, by PD-L1 and other things?
Well, that's a really great point, Tom. And I suppose this was an initial scoping of the community, but because those have prognostic value, if patients do better on trastuzumab or immunotherapy, it might be important to do that. And you're right, so there is a big difference between someone who has 3 liver mets and a patient who has maybe a small para-aortic lymph node. And so you might want to give longer duration of chemotherapy to the person with liver mets. So maybe we should think about having some flexibility and saying a minimum of 3 months and maybe up to 6 months, and that would allow everyone to
and I think
give what they're comfortable with.
And I think the point about, so-called adjuvant treatment, but particularly if treated with sort of stereotactic treatment for synchronous metastases in a HER2 PD-L1 positive, we don't want to deny them longer term systemic therapy as well.
Important, yes.
And I think calling it curative is potentially curative, isn't it? But realistically, we don't know that, and that's why we're doing the trial. In a way, aren't we? We're giving them potentially radical therapies, but we don't know whether it's better than systemic therapy alone. So. I think it is important to look at those, both the upfront primary and the adjuvant treatment.
It's a great point, Tom. I think the point a lot of us have made when we've been discussing this is it's a difficult trial because there's so many variables, and it's a difficult trial because the patient numbers will get very small in certain groups once we start cheese slicing it. And I think a lot of us, we've talked about trying to make it as pragmatic as possible, and we tried to make as much of the trial as kind of dealer's choice up to the point where you do the surgery plus liver resection or surgery plus SABR or surgery plus whatever. But there's always that tension, isn't there, between that disrupting the ability for us to understand the results versus reflecting real life experiences and MDT actions. It's tricky.
Sam?
Oh, hi. I don't have my hand up, but obviously we could go on talking about this for the next half hour. So thanks for bringing this into the meeting. Was there anything further that you wanted to share with the audience? Because otherwise, we've hit the 1.5 hour mark, and as you probably know, commitments start. I've got to be going down to clinic, and I'm obviously the host of this meeting, and I'm recording this meeting. So I was just wondering if there's anything further that anyone wants to add before we come to a close.
No, just thanks to everyone. And I think that what we could do is I'm going to put my email in the chat, and if anyone, maybe Chris, you could too, and if anyone has any further comments or suggestions, this is very much a work in process, and we're very grateful to hear all your points. I think that's been a really healthy discussion today, so thank you.
Thank you very much, Lizzie. So the emails, both emails are on the chat. What I'm going to do is I'm going to close the meeting now. So thank you very much for inviting us. We hope you found those 3 presentations interesting, and hope to see you again very soon. Okay.
Thank you for a great MDT.
Thank you.
Thank you very much.
Bye-bye.
Thanks, everyone.